Thank you for joining us for the 4th Annual Global Summit on Kidney Innovations. Global Kidney Patient Voice, the key to accelerating innovation. A collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Richard Knight, and I serve as president of the American Association of Kidney Patients. I'm a former dialysis patient and was blessed to have received a kidney from a living donor over 16 years ago. I first joined AAKP back in 2008, and after 2 years on dialysis and having a transplant in 2006, I considered myself to be very, very fortunate. And I was seeking a way to be more engaged and involved in the kidney community. And that's when I filled out an application to join the AAKP Board of Directors. And I have been very, very pleased since that time. As I look over my past involvement with AAKP, I've had the opportunity to work with the Kidney Precision Medicine Project, which is over at the NIDDK, National Institute of Health. I've been involved in the Scientific Registry for Transplant Recipients. I've attended numerous events and have had the chance to work with some of the best and the brightest healthcare professionals and patients who are clearly committed. But the most important thing that I feel very, very thankful for is the opportunity to voice my concerns to those on Capitol Hill who are responsible for making the laws that will have an impact on our patient lives. And having done so, I invite and I encourage all of you to join us. We need to be as united as possible. We have many initiatives that will allow one to do so. And as a member of AAKP, you can do the same. It is critical now that we as patient consumers raise our voices and create the demand for diagnostics and devices and biologics in our respective independent countries. Through AAKP Global, which was launched in 2019, AAKP is engaged internationally because we are committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new innovations in treatment, and the opportunity to save more lives. We believe that a united patient voice can drive innovation and policy decisions that determine timely regulation and payment for new and safe care treatments. Globally, we work with patients, medical professionals, researchers, and medical industry allies to cultivate a united consortium that is in fact led by patients. AAK believes that this international consortium can advance innovation and change kidney care in countries where healthcare systems and infrastructure do not support patient consumer choice or access to many care treatments. With that backdrop, I am pleased to introduce today's session titled Science and Discovery with Global Implications. I am now pleased to introduce Dr. Mariana Mureau, Associate Professor of Nephrology at Wake Forest University School of Medicine. Dr. Mureau joins us to discuss her research on conventional dialysis versus incremental dialysis and the impact of preserving residual kidney function in CKD patients. AAKP was honored to join Dr. Mureau in her grant submission to the Patient Centered Outcome Research Institute, known as PCORI, to hopefully obtain funding to conduct a broad pragmatic study on this issue. Thank you for joining us, Dr. Mureau. I turn it over to you.
Hello. I would like to thank the American Association of Kidney Patients and George Washington University for the opportunity to present here today at the 4th Annual Global Summit on Kidney Innovations. I'm Mariana Mureau, and my presentation is titled A Kidney Function-Based Approach to Individualized Hemodialysis. The key message that I want to convey by the end of this presentation is that hemodialysis care should become individualized. This message is rooted on the following rationales. There is no biological and scientific justification as to why individuals with appreciable levels of kidney function are straightway submitted to the same full dose and frequency of hemodialysis as those who have negligible levels of kidney function and have been on hemodialysis for years. There is no medical rationale as to why residual kidney function is important in the treatment with peritoneal dialysis, but not for treatment with hemodialysis. Therefore, hemodialysis prescription must be tuned according to kidney function levels and clinical needs for each individual. Presently, the diagnosis of end-stage kidney disease, as we commonly regard it, delineates the transition to dialysis for the management of kidney insufficiency. The word end-stage sets us up into thinking that the kidneys are no longer functional, and dialysis is offered as a replacement of the kidneys. And with in-center hemodialysis, treatments have been conventionally automated to 3 sessions per week at predetermined targets that presume that patients have virtually no kidney function. But according to the USRDS data, kidney function, which is shown in this bar graph as GFR at hemodialysis initiation, spans a wide range of levels. So there is no doubt that there is significant phenotypic heterogeneity among adults who start hemodialysis. And so to shift from the present cohort-based care to person-centered care, it would be more suitable to use the term kidney dysfunction requiring dialysis to signal the need to supplement medical treatment with dialysis and take into consideration ongoing residual kidney function levels for any dialysis modality that is elected. Present dialysis as kidney assistance therapy. And for in-center hemodialysis, individualized treatments which may consist of initial twice-weekly hemodialysis treatments when there are appreciable kidney residuals, and then migrate to conventional thrice-weekly hemodialysis when the residual kidney function is minimal and depending upon clinical needs and patient preference. This hemodialysis treatment model that starts with fewer hemodialysis sessions per week before full dose thrice-weekly hemodialysis is prescribed has been dubbed incremental hemodialysis. Let's remember and keep in mind that patients treated with conventional thrice-weekly hemodialysis and their caregivers give higher priority to ability to travel, dialysis-free time, and not feeling washed out after dialysis. And they give much lower priority to dialysis clearance indices and other biochemical parameters that physicians focus on. Powerfully called out by AAKP leaders Paul Conway and Richard Knight, many patients are put on care regimens like in-center dialysis without being asked what their aspirations are. And the status quo technologies severely limit the types of care presently available. Now, to these statements, I want to add that underneath all this, there is also a status quo mentality and appetite to study and employ hemodialysis treatment models responsive to each individual's needs. Let's briefly look at the science behind thrice-weekly hemodialysis and the hemodialysis dose. The frequency of thrice-weekly hemodialysis was founded in 1960s and early 1970s on the basis of an observational and incremental process. Patients were started on once-weekly hemodialysis, and when the residual kidney function deteriorated, frequency was increased. In fact, Clyde Shields, the first adult to have been prescribed chronic hemodialysis, was treated on an incremental hemodialysis schedule and survived 11 years on dialysis. Once reimbursement for chronic hemodialysis was guaranteed through Medicare, thrice-weekly hemodialysis became an entrenched practice, and so far research funding has been allocated solely for studies that tested more frequent and more intense dialysis. Very importantly, hemodialysis-based KD/V clearance thresholds below which patient outcomes are worse have been validated in clinical trials that excluded patients who had residual kidney function. So while we acknowledge the life-saving benefits of conventional hemodialysis for patients without residual kidney function, we must point out that observational studies have shown a lack of clinical benefit with full-dose thrice-weekly hemodialysis when patients do have residual kidney function. For example, in the Netherlands cooperative study, substantial levels of residual kidney function were present in more than 80% of patients at hemodialysis initiation. And as expected, kidney residuals waned over time. Although indeed a survival benefit was noted with full thrice weekly hemodialysis kD/V clearance in patients without kidney residuals, when patients had residual kidney function, there was no survival difference between full thrice weekly hemodialysis clearance or less hemodialysis clearance per week. These results indicate that a lower hemodialysis dose per week is sufficient for patients with residual kidney function compared to those without kidney residuals, which is intuitively intelligible, as the aim of hemodialysis treatments is to compensate for low kidney function, not to be administered irrespective of kidney residuals. Similar findings were echoed by Kalantar and colleagues in a large cohort of patients initiated on thrice weekly hemodialysis in the US. In their analysis, while the association between lower thrice weekly hemodialysis clearance categories and worse patient survival was present in patients without residual kidney function, patients who did have residual kidney function did not fare worse when hemodialysis treatment was in lower clearance categories. Let's contrast now the approach to dialysis prescription between peritoneal dialysis and hemodialysis. As we know, incorporation of residual kidney function is an integral part of hemodialysis. For many patients who have appreciable levels of residual kidney function, peritoneal dialysis is usually started with lower dwell volumes or fewer exchanges. And as residual kidney function declines in time, the peritoneal dialysis prescription is augmented according to clinical needs. In contrast with hemodialysis prescription, we do not assess residual kidney function. All patients are started with same full dose conventional thrice weekly hemodialysis, and we do not monitor and incorporate the contribution of residual kidney function to their hemodialysis treatments. And although I'm raising on this slide the question as to why there is this discrepancy between how hemodialysis and peritoneal dialysis are prescribed, to discuss the reasons behind this disconcerting discrepancy is beyond the scope of this presentation, but suffices to say, again, there is no medically sound rationale why residual kidney function has zero importance in hemodialysis and should not deserve the same attention when patients are treated with hemodialysis. So what does it mean to incorporate residual kidney function into the hemodialysis treatment plan? There are well-studied mathematical formulas that translate residual kidney function into weekly urea clearance units. There are also electronic tools that aid with this calculus, like links shown on this slide. If we incorporate residual kidney function in hemodialysis prescription, we could render less frequent hemodialysis initiation practicable. Hemodialysis prescribed at lower schedules than thrice weekly has been endorsed by the Kentucky Clinical Practice Guidelines for individuals with kidney urea clearance above 2 milliliters per minute. As sketched on this graph, kidney urea clearance levels above a certain threshold can contribute to total weekly solute clearance and replace 1 or 2 sessions of hemodialysis. In fact, kidney residuals not only can replace one hemodialysis session, but they supplant dialysis-based clearances by eliminating toxins that cannot be removed with dialysis. In time, as residual kidney function diminishes, hemodialysis prescription can migrate to conventional thrice weekly hemodialysis to maintain the minimum total solute clearance level per week, as long as the treatment plan is congruent with patients' goals of care. This model of slower incremental hemodialysis start has the potential to improve patients' quality of life while not compromising clinical outcomes or perhaps even improving clinical outcomes. And it can also reduce instances of hemodialysis undertreatment by freeing resources for individuals who need more frequent hemodialysis than thrice weekly, or who need to reschedule their hemodialysis session because of personal scheduling conflict. In the field of incremental hemodialysis, there has been a growing number of observational studies conducted either retrospectively or prospectively that compare clinical outcomes between twice-weekly incremental hemodialysis start and conventional thrice-weekly hemodialysis in patients with residual kidney function at hemodialysis initiation. And I will briefly review just a couple of these studies here. A retrospective analysis conducted by Obi and colleagues pointed to no patient survival differences as shown in the Kaplan-Meier figure across an entire cohort of patients treated with twice-weekly hemodialysis start and those treated with conventional thrice-weekly hemodialysis. In subgroup analysis, however, shown in the forest plot, twice-weekly hemodialysis start was associated with higher mortality in patients if patients had inadequate baseline residual kidney function levels, which according to this study were kidney urea clearance less than 3 milliliters per minute per body surface area and urine volume less than 600 milliliters a day. These results underscore the importance of proper patient selection, proper longitudinal monitoring of residual kidney function, and timely transition to thrice-weekly hemodialysis when the residual kidney function becomes too low. In a recently prospectively conducted study at one large center in France, a remarkable 58% of patients newly started on hemodialysis were prescribed incremental hemodialysis with 1 or 2 initial hemodialysis sessions per week. The investigators found no survival difference between the incremental group and a propensity score match group treated with conventional thrice-weekly hemodialysis at the same center, shown in the left-sided graph, or a propensity score match conventional hemodialysis group derived from their national dialysis registry, shown in the middle graph. Persistence on less frequent hemodialysis was about 50% at 1 year and 35% at 2 years, shown in the right-sided graph. Other interesting findings in the study were that the hospitalization rate and time to first hospitalization did not differ between hemodialysis treatment groups, and the incremental hemodialysis policy allowed a 16% cost savings. Notwithstanding the encouraging observational data, there is a noteworthy shortage in applying individualized twice-weekly hemodialysis start in clinical practice, partly because this model has not been validated in randomized controlled trials. The good news is that there is a number of pilot feasibility trials that are being conducted, 2 of which have been concluded, and I will briefly review in the next slides. The first feasibility study was conducted in UK by Villar and colleagues. This pilot trial enrolled adults with kidney urea clearance of 3 milliliters per minute or more who were on hemodialysis for no longer than 3 months. 26 adults were randomized to conventional thrice-weekly hemodialysis and 29 were randomized to twice-weekly incremental hemodialysis, which was subsequently titrated to achieve a minimum total weekly urea clearance that was inclusive of residual kidney function. At 12 months, there was no difference between the groups in patient survival, rate of residual kidney function decline, or patient-reported outcomes. But remarkably, the hospitalization rate was approximately 60% lower in the incremental group, and there was significant dialysis-associated cost reduction in the incremental group. The second feasibility study was conducted in North Carolina and included adults who had a minimum glomerular filtration rate of 5 and a minimum urine output of 500 mL a day at hemodialysis initiation and who received no more than 6 hemodialysis sessions. 23 adults were randomized to receive twice-weekly hemodialysis and adjuvant pharmacotherapy for 6 weeks, followed by thrice-weekly hemodialysis, and 25 were randomized to conventional thrice-weekly hemodialysis. At a mean follow-up of 10 months, participant adherence to the prescribed hemodialysis schedule was 96% in both treatment groups. All participants adhered to serial timed urine collection, and remarkably, we also noted a trend to fewer hospitalizations in the incremental group as shown in this graph, similar to results seen in the UK pilot study. There were no safety signals for death, intradialytic hypotension, ultrafiltration rate, or pre-dialysis electrolyte levels in either of these pilot studies. So together, these pilot data have indicated that incremental hemodialysis is safe and feasible and will hopefully pave the way for future larger randomized clinical trials. Before I conclude, I want to take a larger view at future work that is needed for the ultimate goal of providing person-centered hemodialysis. At least three dimensions need to be addressed to achieve this goal, and I classified these dimensions into the external environment, that consists of the need for rigorous scientific basis in the form of comparative effectiveness clinical trials of incremental versus conventional hemodialysis, the need for assimilating residual kidney function monitoring into hemodialysis quality metrics, and justification of full dose hemodialysis in patients with appreciable levels of residual kidney function, and the need to reform payment models that reward person-centered care instead of incentivizing more procedures. Then there is the internal environment consisting of workflows at outpatient dialysis units that need to accommodate varying patient-centered hemodialysis schedules and kidney function monitoring. And last but not least is the dimension of patient factors, which encompasses adequate patient selection and monitoring for incremental hemodialysis, proper patient and caregiver education, and bidirectional decision-making responsible to patients' goals, unrestricted by other performance metrics. So in conclusion, individuals with residual kidney function were not represented in the hemodialysis dose-defining clinical trials, and one size hemodialysis fits all treatment approach is flawed. Every day, a substantial proportion of patients are deprived of the option of slower hemodialysis start. Clinically matched, incrementally prescribed hemodialysis has the potential to transform the care into individualized, person-centered hemodialysis treatments and society-mindful resource usage. Randomized controlled trials are needed to conclusively delineate the effectiveness and operational needs of incremental hemodialysis across varied healthcare systems and dialysis organizations. And finally, the power needed to achieve the goal of individualized person-centered hemodialysis transcends many dimensions. And for that reason, multi-level stakeholder awareness and engagement in this goal will be required. Thank you again for this remarkable opportunity to present here at the American Association of Kidney Patients and fourth annual Global Summit on Kidney Innovations. And I thank everyone for their attention. Thank you.
Thank you for a great presentation, Dr. Mureau, and we continue to wish you the best on your PCORI submission. We all hope for a positive outcome.